welcome in tonight scientific activity of IAVA. This is one of the cardio risk waves. This is the second one in 2021. Today's wave is concerned mainly with heart failure. I'd like to thank Novartis company for supporting CMA activity. I'd like to thank the faculty and ICOM for technical support. We'll start the first session chaired by Professor Nabil Farag, and Professor Sameh Shaheen is unfortunately not with us till now. The speaker will be Dr. Mahmoud Hassanein. I will leave the mic to Professor Nabil Farag to start the first session. Dr. Mahmoud, اعمل share screen. Dr. Nabil, تفضل.
I would like to thank Professor Ashraf Reda for inviting me to talk in this webinar or in this virtual meeting. I would like to comment on this IAVA group. It is a group of professors who are interested in research. Where I would like to congratulate them on the recent publication of the Cardio Risk Project. It was a very interesting paper. I read it with a great interest. Again, I congratulate them. I hope that this research, multi-center studies, would be repeated in other domains in cardiology. We need them very much. We remember the National Hypertension Project by Professor Mohsen Ibrahim and his group, and then the heart failure registry. Many professors in this who are attending this virtual meeting with us, Professor Nabil Farag, Ashraf Reda, Atif Al-Bahri. I don't like to call all names. I may forget some of them, like in Kano, they were sharing in this registry. We hope that this type of multi-center studies would always be carried out in Egypt. We need these data. I'm going to talk about insights from a nationwide registry of heart failure. This was a part of the European Society of Cardiology Heart Failure Long-Term Registry, which was a prospective multi-center observational study of patients presenting to cardiology centers in European and Mediterranean members of the ESC. Egypt, as a full member of the European Society of Cardiology, participated in this registry and contributed the largest number of patients enrolled in the registry. From April 2011 to February 2014, a total of 2,145 patients with heart failure were recruited from 20 centers all over Egypt. The aims of the study were to describe the demographic and clinical characteristics and management of patients hospitalized with acute heart failure and patients with chronic heart failure seen as outpatients in cardiology centers in Egypt, and to compare heart failure patients from the Egyptian cohort with heart failure patients with other European countries participating in the same registry. This is the data of the Egyptian cohort, and I'm going to talk about patients hospitalized with heart failure, not outpatients with heart failure. This was the first publication in 2015, Clinical Characteristics and Management of Hospitalized Ambulatory Patients with Heart Failure, results from the ESC Heart Failure Long-Term Egyptian Registry. It was published in the ESC Heart Failure Journal, and as you see the names of the co-authors, many of them are present with us today. So the centers that you see were distributed evenly all over Egypt: Alexandria, Port Said, other governors in the Delta, Tanta, Nufia, Zazi, and from Upper Egypt like عندنا أسوان وعندنا سوهاج وعندنا كمان طبعا Greater Cairo. This is the disposition of patients. We had 1,475 patients hospitalized with heart failure and 670 patients as outpatients. I'm going to describe the data of patients hospitalized with heart failure. So the mean age of our patients was 60 years, And if you compare this with European patients with heart failure, the mean age was 73. So there is a difference of about 13 years between the Egyptian patient and European patient. Body mass index was 30.28, which means Egyptian patients are obese. And this is again, obesity was more prevalent in Egyptian patients versus European patients. And the mean ejection fraction was 38%. If we look to patients above the age of 70, there were only 23% of patients above the age of 70. Females comprise 30% of our patients, and almost 47% of patients were obese, body mass index above 30. And patients with preserved ejection fraction, which at that time was only 45%, later it was 50%. But at that time, 2015, an ejection fraction above 45% was considered heart failure with preserved ejection fraction. Only 22% of our patients had heart failure with preserved ejection fraction. Diabetes mellitus was present in 45% of patients, hypertension almost 44%, smoking was present in 61% of our patients. The main etiology of heart failure, the main underlying etiology was ischemic heart disease. 68% of patients had ischemic heart disease, 15% dilated cardiomyopathy, almost 4% hypertension, and almost 8% valvular. So this stresses the importance of ischemic heart disease as underlying cause of heart failure. And this tells us much that heart failure is preventable. If we can prevent ischemic heart disease, the incidence of heart failure would decrease dramatically. Now we come to the comparison between Egyptian patients and European patients who were recruited in the same registry at the same time. So those above the age of 70 comprised only 23% in Egypt compared to almost 60% in Europe. You see the big difference in those in the elderly. Body mass index above 30, which is index of obesity, it was 47% of the Egyptian patients versus 28% of Europeans. Females comprise 30% of our population versus 39% of the European. Preserved ejection fraction was present, as I said before, in 22% of our patients versus almost 36% of European patients. And the prevalence of atrial fibrillation was 24% in our patients versus 48% in European patients, almost half the prevalence of atrial fibrillation in our patients. For risk factors, diabetes mellitus was more common in our patients, almost 45% versus 35% in Europeans. Hypertension, on the other hand, was more prevalent in European patients, 70% versus 43%. Smoking was more prevalent in Egyptian patients, 61% versus 47% in Europeans. Other comorbidities such as renal dysfunction, prior stroke, peripheral arterial disease were more common in European patients. The only exception was the hepatic dysfunction, which was more prevalent in our Egyptian population, perhaps might be related to hepatitis C, which is endemic in Egypt. The second publication was about gender differences in Egyptian patients hospitalized with heart failure. There was no difference in the mean age, 60 years, whether men or women. Women presented with a higher systolic blood pressure and a higher resting heart rate. Obesity, again, look to this very carefully, 66% of women had a body mass index greater than 30 versus only 43% of men. So it's a big problem among our women, Egyptian women. Almost 2/3 of Egyptian women hospitalized with heart failure were obese. And this, I took this snapshot from our screenshot from the great publication by your group, which is prevalence of risk factors in Egyptian patients with acute. Again, the same observation that Abdominal obesity was a very important risk factor for patients with acute coronary syndrome. And if you look to the down the slide, hypertension was more prevalent in females. Diabetes was more prevalent again in females. Obesity was more common in females. If you look to the bar charts in the bottom of the slide, these are the same observations in our Egyptian patients with heart failure. Women had more diabetes, had more hypertension, and were more obese. Etiology of heart failure, there was no difference in the etiology between men and women. However, atrial fibrillation was more common in women, about 34.7% versus 22.4% in men. Again, diabetes mellitus was more common in women, hypertension was more common in women, but smoking was much more prevalent in males versus females. If we look to the phenotypes of heart failure, reduced heart failure with reduced ejection fraction were the most common phenotype of heart failure in our patients. But look to those with preserved ejection fraction. Here, this was a later publication, and here the ejection fraction was taken as a cutoff point above 50%. Almost 30% of women had heart failure with preserved ejection fraction versus 11% of men. So women had more preserved ejection fraction, and you can attribute this to the more prevalence of hypertension, diabetes, and atrial fibrillation and obesity in women. Precipitating factors for heart failure, myocardial ischemia was more common in men, but atrial fibrillation, uncontrolled hypertension, and anemia were more important precipitating factors for heart failure in women. Comorbidities with heart failure, anemia was more common in women, diabetes, hypertension, but renal dysfunction, hepatic dysfunction, and chronic obstructive pulmonary disease were more common in men. If you look to the in-hospital and one-year mortality, there was no difference between men and women concerning the in-hospital mortality and one-year mortality. So in summary, this was the first national large-scale registry of heart failure in Egypt. Heart failure patients in Egypt have distinct demographic and clinical features different from other European countries. Men and women afflicted with heart failure differ significantly in baseline clinical characteristics, but not in adverse outcomes. These findings highlight the value of national registries in planning primary prevention programs. Heart failure management programs should be established all over the country to improve patient management and outcomes. Thank you for your attention.
People who were putting data in the registry were cardiologists of your caliber who treat ischemic heart disease patients. People who treat geriatric patients who might be in heart failure probably did not include them in the registry, and they might have less mortality. So the setting of care, who was looking after those patients, who was putting patients in the registry, and when you have cardiologists who treat intensive care patients, putting them in the registry, then you would expect that these are riskier patients. Possible. It's a possibility.
They were all cardiologists who were involved in this registry. But mind you that they were not all university hospitals. We had some Amin Sahi and even Ministry of Health hospitals. But all contributors were cardiologists. I agree with you, and this is some limitation of our registry, or in general of any registry. These are some of the limitations.
Thank you very much. It's glorious work. We're so proud of it. Thank you.
Professor Mahmoud. Dr. Mahmoud, Ahmed Lirsh عنده comment.
Professor Mahmoud, thanks for this elegant presentation. I think you titled that we have the first causes ischemic heart disease against which is different from Europe, which is hypertension.
لا
So
هو
I think
بص هو في مصر كان 68% of the patients had ischemic heart disease. In Europe
ischemic heart disease.
was 47%. فبرضه it was a significant number of patients from Europe.
Yes, بس احنا اقل الهايبرتنشن اقل في مصر من
yes definitely definitely الهايبرتنشن هقول لك ليه، لان البيشنتس from Europe are more elderly. واخد بالك they had more hypertension, they had more atrial fibrillation, they had more comorbidities than our patients. وده من الاسباب ان هو الهارت failure with preserved ejection fraction is more common in European patients than in our patients, in our Egyptian registry, because of age.
I think we must be more aggressive in treatment of ischemia and primary prevention for ischemia in Egypt. The first.
And I think that if we can reduce ischemic heart disease, وده انتوا you are doing a great job in the EVA group. If we can reduce ischemic heart disease, prevalence of heart failure in Egypt will be much reduced. We all see that most of the patients admitted with heart failure have ischemic heart disease. Most of the patients we see in our wards. I think you agree with me.
Dr. Mahmoud, is really a great work actually, and I remember that a few years ago there was a similar project regarding acute coronary syndrome with the European Society of Cardiology, and many of us was involved in that registry. However, there is no activity about this registry. That's why I think your leadership to this registry had an important implications on the how to utilize the data, following up the publications, announcing for the results. So I think all of us have to thank you, and we are honored of having you as a leader for this very important.
Thank you, Professor Ashraf Rida. I
would like to ask Dr. Mahmoud a question.
Yes, of course.
Okay,
Dr. Mahmoud, I'd like to thank you first for this great presentation, and I would like to ask you about patient with heart failure with preserved ejection fraction in Egypt. And as we know from the literature that it represents more than 50% of patients coming to the ER all over the world. And then here in Egypt, it is not more than 30% of the patient. In Europe, it is 35. In Egypt, it's less than 30 even. Do you know the reasons behind this?
Yes, thank you for this question.
Is due to such
the situation is different. If you look to outpatients or patients who are coming to the heart failure clinic, you will find a higher percentage of heart failure with preserved ejection fraction. Okay, because usually the patients who are who come to the hospital and admitted, those are patients with advanced heart failure and they have reduced ejection fraction. ده one point. يعني أنا بقول يعني إذا لو أنت قررت نفس السيرفي ده هتلاقي إن ال prevalence of HFpEF is more in outpatients than the inpatients. الحاجة الثانية إن هم in Europe and America the patients are aged and elderly. والHFpEF is more common in the elderly اللي هو above the age of 70 or 80. This is عشان كده هم عندهم الHFpEF بيبقى مثلا يوصل ل 50% 50% of the patients. They have the risk factors for HFpEF اللي هو hypertension, atrial fibrillation. واخد بال حضرتك يمكن دول are more prevalent زي ما شفت. يعني عندنا atrial fibrillation only 24%, عندهم 40%. The difference in age, hypertension in the elderly is more prevalent. كل دي اسباب بتخلي الHFpEF is more common in European countries. وده موجود في امريكا ويوروب، مش موجود مثلا عندنا. وبرضه في ايشيا ساوث ايست ايشيا في هارت فيلر سيرفيز برضه الHFpEF عندهم is not so common as in Europe and America. فعشان كده احنا ساعات لما بنتكلم وبنقول ارقام من يوروب ويونايتد ستيتس we think that these figures apply to us to Egypt. لكن زي ما شفت الداتا اللي حضرتك عرضناها واللي حضرتك شاركت فيها مع الزملاء ان Egyptian patients are different حاجات كتيره جدا. يعني انا اتذكر مره طلاب من فرنسا، تبادل طلابي ما بين فرنسا وجامعه فرنسا، فالطلبه الفرنساويين دخلوا فقلت لهم ايه which struck you first قالوا لي ان لا، العيانين في مصر ار يانج، شباب بالنسبه للعيانين اللي عندنا. بنخش عندنا العنبر عيانين في ال70s وال80s، انتوا عندكم هنا البيشنتس ان ذير 50s. وانا عايز اقول للدكتور اشرف ده انا بشكره على طبعا مع النخبه العظيمه على الكارديو ريسك بروجكت، لان لما قريت البيبر وقريت يعني مور ذان وانس، the same risk factors اللي عندكم في البيبر هي the same risk factors in our patients with heart failure. prevalence of obesity, diabetes, hypertension، كل الحاجات دي بتأكد ان these are the data are consistent ما بين your findings and heart failure registry.
Actually, Dr. Mahmoud, Dr. Nabil, this is very important questions you asked, Dr. Nabil, because I will present in my presentation some data from what's called Olmsted County, which is a state in Minnesota, about heart failure phenotypes, about HFrEF versus HFpEF, hospitalization and prognosis. It seems that the reason behind your question, Nabil, is the complexity of the diagnosis and coding the patient on discharge. Most of the patients of HFpEF are admitted due to hypertension, admitted due to ischemic heart disease. And then we found in the echo report that there is preserved ejection fraction and patient is complaining. So the presence of many comorbidity make the diagnosis difficult.
Yes.
طبعا الdiagnosis of HFpEF is difficult. Whether in Europe and the United States.
If you repeat this register, know what's HFpEF? Yeah, no, I know.
It needs a cardiologist to make the diagnosis.
Yes, yes. Thank you very much, Dr. Mahmoud, for this excellent presentation and discussion. And I think we have to move to the next session.
Let me take a 50-second break till preparing for the next session, Dr. Nabil. Okay. Thank you very much. Thank you for the faculty. Be with us. 30 seconds, we'll be back again.
Inshallah.
Let us start the second session, and I will lead the for chairperson, Professor Ahmed Al-Irsh and Professor Abdul Shafi Tab. تفضلوا.
Thanks, Dr. Ashraf. Dr. Abdul Shafi.
أيوة دكتور أحمد تفضل.
It's an honor to present my dear Professor Dr. Hani Raghi. He will talk about diagnosis of heart failure, role of natriuretic and pro-PNP.
Thank you very much, Professor Tab. I'm just connecting my speakers. I hope I have a clear presentation. I hope you can hear me well.
Yeah.
I'm honored to be in this group today, and I'm particularly honored to be talking about after Professor Mahmoud Hassanein, one of the Egyptian leaders in the field of heart failure, and is the one who provided us with all the new Egyptian data. I'm going to briefly discuss the diagnosis of the role of the natriuretic peptides and the pro-BNP in diagnosing heart failure. Actually, the anti-pro-BNP empowers better heart failure management at every stage, not at just diagnosis. So what is the beta-type natriuretic peptides? What is that? This is a protein where increased myocardial wall stress due to either volume or pressure overload activates the beta-type natriuretic peptide gene in the cardiac myocytes, producing the intracellular precursor propeptide, which is the pro-BNP. And the cleavage releases the biologically active BNP, the brain natriuretic peptide, which is a vasodilator, and it's supposed to help you when you have increased atrial pressure and heart failure, and the biologically inert amino-terminal fragment, the NT-proBNP. The BNP stimulates natriuresis, it's vasodilatation, with consequent afterload reduction. It's one of the body's natural mechanisms of fighting heart failure. It inhibits renin-angiotensin-aldosterone release and inhibits sympathetic nervous activity, and it actually reduces fibrosis. And obviously, what is NT-proBNP? It's a protein released by the heart. This is a slide which is prepared for the layman, not for doctors, but it's important to read it. Because the NT-proBNP, as I just showed you, is a protein released by the heart when the left atrial wall is stretched. And when the NT-proBNP levels in the blood are low, heart failure can actually be excluded. But raised NT-proBNP levels in the blood can indicate that someone has heart failure, and the levels tend to rise with the disease's severity. Actually, I did not have time to put a slide of a patient that I saw last night. A young man with an ejection fraction of 50 and extreme dyspnea, hemoglobin A1C of 14.6, what looks like an almost normal echo, but severe symptoms. ECG just saw some LVH and mildly hypertensive. His high sensitive troponin was 10 and was repeated 2 hours later, was normal. His NT-proBNP was 25,000, and the normal cutoff point to rule out heart failure is 300. And this patient was actually in acute heart failure. So while monitoring patients' state over time, you can also keep following the NT-proBNP. It will give you information about progression or improvement of the patient's condition. Heart failure denies the patients the freedom to live well, especially in the older years. And as you are very familiar, the symptoms are of shortness of breath, leg swelling, fatigue, and limited mobility. So how can you use the NT-proBNP in any stage of heart failure? In diagnosis, it will actually help you, like the patient I just talked about yesterday. It will improve heart failure diagnosis while saving on echocardiograms, saving on time spent in emergency departments. Yesterday's patient actually had a normal echo and was a little bit wheezy. So I was confused because he was a smoker. Was this acute dyspnea something related to chest? Was it a COVID case? But the NT-proBNP immediately showed me that my patient had very severe heart failure with preserved ejection fraction. It was ridiculously high. And this patient, by the way, underwent CT chest today. There's no evidence of COVID, but only of congestion. He's already on massive diuresis, and even in 1 day, his reporting is a little bit better. Inside hospital, so what you have a heart failure patient hospitalized, and you do an NT-proBNP on admission and say it's 10,000. And 3 days later, your patient is asking you to go home because old people don't like hospitals. And you do another NT-proBNP and it's 3,000 instead of 10,000. Discharge the patient. This patient is going to do well. However, if you do another NT-proBNP 3 days later and the one which was 10,000 is now 15,000, let me tell you, if you discharge this patient that day, he's going to be back at night, okay, with pulmonary edema. So it'll help you in hospital management. It'll also help you in disease monitoring. It's an objective, easy-to-use tool for monitoring patients' condition to improved outcomes, especially those on sacubitril valsartan. So let me tell you, in the United States of America, you can monitor your heart failure patients by many methods. One of them, and this is done by heart failure nurses, one of them is to put a floating pulmonary artery catheter with a Bluetooth, which sends you the pulmonary artery pressure if they're in another area, in a remote area. And if you find that they're increasing their pulmonary artery pressure, then you can actually ask them to come back before they develop an acute on top of chronic heart failure. The same goes for weight, following them by weight, but this is actually a late finding. Your patients start to put on weight quite late in the disease. But you have to find a way of following them. And one of the very good ways of following them is by asking them to do a NT-proBNP and send you the result. Again, I'm very much for using it. And what the opinions which are said here, some of them are not necessarily in the guidelines, but maybe my own opinions and groups of other doctors performing heart failure. So I will also mention the role of BNP in the guidelines, which is not necessarily proven as I just described in those 3 stages. So as you know very well that our targets in many cardiovascular disease is to reduce mortality. But in heart failure, of course, that remains our ultimate target. But our other very, very clear target in heart failure, which we don't have in, for instance, in angina pectoris, is to reduce rehospitalization. because our heart failure patients are really frequent flyers. They just keep getting hospitalized, and every time they get hospitalized, their mortality rises. About 1 every 4 patients, that's 25%, will be readmitted within a month of being discharged. And about 50% will be readmitted within 6 months of being discharged. And more than 1 in 2 will die in 5 years. Survival rates in heart failures are worse than major cancers like bowel cancer, breast cancer, and prostate cancer. The only cancer which is worse than heart failure is lung cancer. And currently, there's a real unmet need in diagnosing heart failure. So heart failure symptoms are not specific. They're hard to tell apart in elderly and lung disease patients. And let me tell you, in Switzerland, elderly women ride bicycles, okay? And they tell you that when they were going to the market on their bicycle, they felt short of breath. None of our grandmothers rides bicycles, okay? Our grandmothers sit at home thinking that their dyspnea is part of growing old and being overweight. And they might be in severe heart failure without actually recognizing very much, and the symptoms are non-specific in the elderly. Echocardiograms are resource intensive and are difficult to do. Some of our elderly patients can't move. You can send somebody at home and get an NT-proBNP sample without the difficulty of doing an echo. Having said that, echo in Egypt is cheaper than BNP. Professor Mahmoud Hassanein just told us something which is a sad reality, that they did not do BNP because in the registry, because it was expensive and the sponsoring company did not sponsor it. Let me tell you that I do the BNP. I do the BNP in Egypt for 50 Egyptian pounds, okay? Because I have my own machine, and that is the cost of the tape, and I don't charge the patients for it. Some labs will do it for 1,000 Egyptian pounds. So that is 20 times the cost of, and this is something we have to address. We need for early and accurate heart failure diagnosis to improve outcomes and save resources. You don't want to wait till your grandmother who's sitting at home being short of breath and everybody is telling her, oh, it's because you don't move, suddenly goes into pulmonary edema and goes to hospital, because then she will have high mortality. So NT-proBNP can diagnose her for you quite early. Inside the hospital, you need to aid discharge planning to avoid early readmission, as I just said, and in disease monitoring, as I just explained. The major guidelines actually recommend the use of natriuretic peptides at diagnosis of heart failure. So the 2016 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure and the Canadian Cardiovascular Society and the ACC, they all recommend using the natriuretic peptides. Upon presentation, a measurement of natriuretic peptide is recommended in all patients with acute dyspnea and suspected acute heart failure to help in differentiation of acute heart failure from non-causes of acute dyspnea. And that's class 1, level of evidence A. And for NT-proBNP, you recommend a cutoff point of 300 picograms per milliliter to rule out acute heart failure in an acute setting. So if you do it and your patient has 100, this is not acute heart failure. Plasma concentration of natriuretic peptides is classified as an essential initial investigation, especially in the non-acute session and especially when echocardiography is not immediately available. Let me just mention one more point about echocardiography being not immediately available. There is a difference between having an echo machine and between having a proper echocardiographic exam with a proper ejection fraction being measured. And I can claim here that 90% or 95% of ejection fractions which are being measured in Egypt now are observer eye observations with incredible variability between different operators and even between the same operator on different times. And the patients are extremely alarmed by carrying their own echoes, which have a range of I mean, if we look at the new data, the new definition of heart failure, which is so specific regarding the EF, I would say that many of our echoes are jokes because nobody is connecting the patient to an ECG. Nobody is doing multiple measurements using the proper apical Simpson's method. Nobody's using automated ejection fraction. We have a lot of experts who just look and say 50%, and the same patient 2 days later is 32%. I mean, you know, just do a BNP and you will avoid all this pseudo echo reports that I'm sure are confusing all of you as much as it's confusing me. And in the non-acute setting, the rule-out number is only 125. So in an acute setting, it's 300. In a non-acute, it's 125. You can use, that is the patient who's coming for you. So you want to avoid resource wastage in echocardiograms. The NT-proBNP is less than 300. Negative predictive value is 98%. The heart failure is unlikely. Look for other symptoms. If it's more than 300, order an echo and have a look. In chronic setting, in non-acute setting, the patient's presenting at the GP or primary care, just do an NT-proBNP, less than 125, negative predictive value, nearly 100%, 97%. Heart failure is unlikely, look for other symptoms. If it's higher, order an echocardiogram. In the emergency department, NT-proBNP usage improves the outcomes while actually reducing costs. It has been looked at, the emergency department visiting hours. If you use NT-proBNP, your patients stay significantly less. If you use it, your patients are less likely to be rehospitalized in the following 2 months. Actually, the costs in America of using it versus not using, opposite Egypt completely, opposite what Professor Hassanein just told us. In America, if you use it, where it's very cheap, the cost of hospital for your patient is less, because in America, hospitals are very expensive. So you have a 40-minute reduction in emergency time versus the usual care, 35% fewer patients rehospitalized in 60 days, and 15% reduction in cost for emergency department visits in the next 60 days versus usual. It saves unnecessary echocardiograms. It saves about half the echocardiograms which you were going to order. You don't need to do them. If you have a normal NT-proBNP, just send the patient home and look for other causes of dyspnea. And this is the British Heart Foundation. One of its top 10 recommendations is to make NT-proBNP available in all emergency rooms and primary care facilities. So the lady goes to her GP, or the man goes to his GP, they are short of breath, they get an NT-proBNP. Recommendation of the BHF, which, as you know, uses the NICE guidelines and is very, very cost conscious. This will save you 1 in 2 echocardiograms according to the UK Southeast cost recommendation cutoff. It is estimated according to the NICE guidelines, which has put the BNP in class 1 usage, to save them £3.8 million sterling by using the natriuretic peptides, plus improving the quality of care. Early readmission is common, and you need in hospital, once you have the patient in hospital, when will you send them home? Okay, when do you send the heart failure patient home? What is your, do you wait for them to go completely dry? If they're really, really improving and they want to go home, do you send them home or do you wait? How can you avoid readmission? The major guidelines recognize the value of natriuretic peptides for the in-hospital management of heart failure. If you use them as pre-discharge assessment for prognostic evaluation and after hospital admission, the patients whose natriuretic peptides concentrations fall during admission have lower cardiovascular mortality and readmission rates at 6 months. This is recognized by both the ESC and the Canadian Cardiovascular Society. Actually, the NT-proBNP level at hospital discharge predicts the 1-year mortality. If you have a patient who had dropped, 50% of patients whose NT-proBNP is more than 3,000 at discharge will be dead within 1 year. So it tells you how risky your patient is. And also the NT-proBNP level, as I mentioned earlier, inside the hospital reflects the risk of readmission. If it rises by more than 30% during hospitalization, this patient is 6.6 times more likely to die or to rehospitalize in the next 6 months. versus a drop of more than 30%. So patients whose natriuretic peptides fall during admission have lower cardiovascular mortality at 6 months. It aids you to plan the discharge and identifies the high-risk patient that you might want to be seeing once a week or even wanting to send a nurse to their home. We have a lot of challenges in monitoring heart failure patients as outpatients, and we need an objective marker to easily monitor the condition for improved outcomes. We can't rely completely on the dyspnea or the leg edema. They're late. We need to tackle the changes in monitoring patients, particularly on sacubitril valsartan. And most of the guidelines also recognize the value of natriuretic peptides in heart failure management. This is not a class 1A that you have to do it, but it is really going to help you because high circulating natriuretic peptides predict unfavorable outcomes in patients with heart failure. And a decrease in BNP during recovery from decompensated heart failure is actually associated with better prognosis. So serial NT-proBNP measurements provide prognostic information. If you look, this is the patient who remains high, they have the worst outcome. The patient who has rising risk doesn't have a good outcome. The patient who was high and is dropping has an improved outcome. The patient who was originally low and remains low has the best outcome. Sacubitril valsartan, you can't use BNP with it because the BNP rises initially. It does actually get better later, and you can if that's the only test you have, but what's recommended with it is the NT-proBNP. The neprilysin inhibitor, you can't use just BNP because it will lead to misinterpretation, and you won't be able to tell if your patient is getting better or worse. But so with the sacubitril valsartan in particular, there is actually a package warning that BNP is not suitable as a biomarker in Entresto because BNP is actually neprilysin substrates and it actually increases while the patient is improving. While NT-proBNP is not a neprilysin substrate and is actually a more suitable biomarker. This is a package interest of the EMEA. So the NT-proBNP on those patients will show you rapid sustained reductions. And just like you see, all of us were very happy to see the echocardiographic remodeling on Entresto. You'll actually see much earlier big drops in NT-proBNP, which is very useful and also important for the patient. So these are my last two slides. Actually, maybe my last two slides. The summary, the NT-proBNP empowers better heart failure management at diagnosis inside the hospital and in hospital management. Let me just tell you my most important slide. Please, if I had lost you, wake up. This is new and it really depends on the age. So you put a cutoff point in acute heart failure of 300 for BNP here, for NT-proBNP for all ages. For BNP, the cutoff point is 100. The heart failure diagnosis is likely with BNP if it's from 100 to 500 and above 500 it's very likely. But look at this, with NT-proBNP, there is actually a major element for aging. So if you get a patient who's the age of 75 with an NT-proBNP of 1,000, heart failure is possible, but other diagnoses need to be considered. If you get a patient who's above 75 and you want to be absolutely sure they're in heart failure, and then they have to be above 1,800. So don't be alarmed. Egyptian labs are not going to write this in the paper coming back to in the report. In your patient who's 75 years old, who has an NT-proBNP of 500, will look at this number and will think that they are bad. Actually, they have no heart failure. If your patient who's 75 years old has a BNP of 500, 600, 700, 800, this is normal because of their age. And as we know, BNP will increase with atrial fibrillation, will increase with kidney failure and other reasons. You have to know the limitations. So we have a single cutoff point of 300, which is 99% sensitive and 60% specific. But to rule in, it's actually a triple cutoff point, depending on the age. Less than 50 is 450, 50 to 75, 900, above 75, 1800. Below that, your patient might not have heart failure. And till we teach our labs to write the normal for age, we have to know that ourselves as physicians. There are obstacles to using the NT-proBNP, which is the knowledge gap, which we're trying to teach people to do it. Availability and is point of care actually stops. Sorry, my dogs are making a noise. Availability can be overcome by using point of care machines. I use a point of care machine where the patient just gets a finger prick like a diabetes machine, and I get the result instantly in about 2 minutes, and it costs me about 50 Egyptian pounds, apart from buying the machine. We have a cheap echo, which you can't compete with, which is very good, but it's not available all the time. And an expensive test should be overcome by Egyptian societies of heart failure and by the medical societies who should insist that this test is both cheap and immediate. You can't have a lab telling you, I'm sending it to Germany and getting you the result in 1 month. It's doing now what your patients need next. I strongly urge you to use NT-proBNP. Let me tell you that in my own practice, and like all of you, I'm a busy cardiologist, there has not been a single day in the last year in which I was practicing, not the weekend, in which I did not order at least once an NT-proBNP. Thank you very much, and I'm happy to take any questions.
Thank you, Professor.
Thank you.
Actually, this is a marvelous presentation. And I know you are expert in using this kind of investigations. You can tell us the difference between proBNP and BNP in your daily practice. But I want to put an important observation based on your last slide, which is the differential level according to age.
Yes.
The reverse is happened with obesity.
Yes.
Obese patient is a problem because obese patient may have short of breath.
Low BNP. Yeah.
May have really heart failure, and his BNP may be low. So this is you cannot exclude the diagnosis of heart failure in obese patient based on just normal BNP or proBNP. So thank you for this extensive coverage, Dr. Ahmed. Any questions from the
Yes.
Yeah. Thank you, Dr. Hani. Dr. Hani.
Thank you, Professor Tab.
Yeah, thank you, Dr. Hani, for this educative talk. I have my own concern about using natriuretic peptide in diagnosis of heart failure. Natriuretic peptide actually presented in the clinical practice many years before, and until now, especially in our National Cardiology Society, actually the majority of cardiologists not use this diagnostic test in our clinical practice. It is not a matter of cost only, but this natriuretic peptide had many limitations. It is not a standalone test. We can't use it without using imaging like it. As Dr. Ashraf recognized, the cut-off value of natriuretic peptide affected by age, by obesity, by presence of atrial fibrillation, by the level of kidney function. Also, many patients with flash pulmonary edema or acute heart failure may have normal natriuretic peptide. Many patients located in the gray zone between ruling out heart failure or approves the diagnosis. So after all this limitation, do you think, sir, using of natriuretic peptide could be applicable or just for research?
I think the use of natriuretic peptide is a huge part of diagnosing heart failure. And the main reasons for not using them is, as you pointed out elegantly now, is a lack of knowledge. So if a cardiologist is unaware of how to use them, like any test, if you're, for instance, echocardiogram, for instance, I can say about echo that there is incredible intraoperator variability that you can't see in emphysematous patients. This doesn't take anything away from echo. because every test has a limitation. So if we know the limitations, I mean, this is the number one test for diagnosing heart failure in the absence of echo. Let me tell you that the majority of people who see heart failure patients are not cardiologists. You need to give them a rapid test by which they can send the patient home or keep the patient in hospital. The natriuretic peptides are in all the guidelines an essential part of the diagnosis of heart failure. So we cannot just come up and say we refuse the guidelines. I mean, we can't do that, So we have to learn how to use them. That's the first thing we have to do. Number one, we have to make sure that we get them immediately and that we can get them repeatedly whenever we want. And the third thing is we have to make sure that we get them for the real price, which is very, very cheap. It's a very cheap test.
ليه كومنت لو سمحتوا.
اتفضل يا بيه.
بالنسبه للنيتريتيك بيبتايدز البوليسي in Egypt is different than the policy in Europe and United States. تلاقي في الجايد لاينز النيتريتيك بيبتايدز come a step before الايكوكارديوجرافي لان البي ان بي النيجاتيف بريدكتيف فاليو زي ما قال الدكتور هاني about 98%. فthis is a filter. You can filter the patients who come to the casualty department اللي جايين بديسنيا و you can exclude almost heart failure by negative BNP test. And those who have a positive test, you send them to echo. And the echo is more expensive in the United States and Europe than the BNP test. BNP test is less expensive. فهو اللوجيك اللي انت بتعمل BNP, those who are negative, you are almost sure that they have not heart failure. And those who are positive, you send them for an echocardiographic examination. زي ما قلنا دكتور هاني راجي ما فيش تيست 100 different يعني لا في limitations. هو قال لك الايج ده limitation لازم تعرفه. presence of comorbidities زي renal failure زي
chronic kidney disease والatrial fibrillation.
اوكي atrial fibrillation مثلا الكات اوف بوينت in the same patient لو عنده atrial fibrillation غير لما يكونش عنده atrial fibrillation. اذا كان ما عندوش 300 اذا كان عنده atrial fibrillation الكات اوف بوينت 600. فهي زي اي تيست عايز some tips and tricks to use. لكن it's very useful test. وهي المشكله انا رايي معلش برضو هي المشكله زي الكوست. It's a cost wise issue. لكن it's very useful in the diagnosis وفي الفولو اب the patient and telling you the prognosis and when you زي ما قال الدكتور هاني when you are going to discharge the patient. لما تلاقي البي ان بي ده بيتغير يوم عن يوم تلاقي البي ان بي بينزل you are quite sure the patient is improving you can send him home.
عندي سؤال هاني محاضرتك رائعه
ربنا يخليك
و to the point very sharp. لكن ال NP levels is lower than expected في الobesity والفلاش pulmonary edema اللي هي في الهارت فيلير. والهارت فيلير اتيولوجي كمان ليها سبب في lowering ال NP. The acute mitral regurg, for example, mitral stenosis or cardiac tamponade, pericardial constrictions. These are some important factors that we find the NP is decreased, and all those patients have heart failure. How can you evaluate that?
Let me tell you, both حضرتك Dr. Tobel mentioned a flash pulmonary edema. When a patient is coming to hospital and is coughing pinky frothy sputum, and I put a stethoscope on their chest and it's bubbling, I really don't see the role for a natriuretic peptide.
Yes.
Okay. I mean, this patient is, why would I even want to do a natriuretic peptide? I mean, the patient, it's like having a patient with a fractured leg, with the leg coming out of the bone, and worrying very much about false negative X-ray. I mean, the diagnosis is just so clear. We worry about natriuretic peptides when the diagnosis is in doubt. I mean, as Professor Hassanein said, the amount of people you're going to send home, the test has a negative predictive value of nearly 100%. Not very many tests in medicine. And the negative predictive value is very, very important. I mean, let me tell you, if you have a patient who's coming to hospital with spontaneous pneumothorax, who's diagnosed as heart failure, you are going to be very happy to do a natriuretic peptide,
Yeah.
So And it's true. And like we said, you just have to know the limitations of the test and
Yeah.
not use it. And also it works with echo. But the ease with which echo is done in Egypt for everybody whose face I see on this screen is deceptive, because that is not the national case for every single patient in the country. Anybody in this screen now can take a mute and order an echo and probably have it done in 5 minutes. That is not the normal way that patients get cared for everywhere. And that is the problem. You know, when I was just talking to Professor Mahmoud Hassanein about all the cases going from Egypt are going from a cardiology setting.
Yeah.
I mean, experienced cardiologists, to be honest, very experienced cardiologists, neither need a BNP nor need an echo to diagnose heart failure. They will diagnose heart failure clinically with incredible certainty. Those tests are done for everybody, okay? It's a screening test. A nurse can do it. So a nurse with no doctor in a clinic can call you and say, Mrs. here and she's a little bit short of breath. You can order NT-proBNP, and she calls back and says, it's 100. And you can say, okay, it's not heart failure. Okay? So I'm not talking about very experienced professors of cardiology. I'm talking about guidelines for all heart failure patients under any system of care.
Thank you, Annie.
Thank you.
And take you into a journey of HFpEF. I know there are some skeptics out there about what is HFpEF. Is it really something? Let's take a case presentation. This is a 67-year-old female. She's hypertensive on 2 meds, perindopril and indapamide, rather hypertensive, diabetic, and taking medication, presenting with shortness of breath and fatigue, which is something we can see in a lot of people, actually. Looking at her body mass index, she's obese, it's 32. Her blood pressure is not that well controlled. Her heart rate is 78. But actually, there are some basal lung rales, there are congestion symptoms, and there's mild ankle edema, which is not attributed actually to any of the medications she's taking for her hypertension, but it could be due to obesity. So again, this is a case presentation of a lady. And you think about it, what could be the problem here? Is it her hypertension? Does she have chronic kidney disease with diabetes causing the problems? Is it heart failure? What type of heart failure, if it is it generalized anasarca? And then you go to the question, what shall I do next? And actually, this patient, we ordered an X-ray. And here, actually, you see there is an increased cardiothoracic ratio. There is a little bit of pulmonary venous congestion, but watch out that this cardiothoracic ratio was actually due to a little dilatation of the left atrium. Her ventricle showed normal dimensions. Her functions were 56%, which is normal. She had mild concentric left ventricular hypertrophy. There is type 1 diastolic dysfunction as seen in the Doppler, as seen below in the figure below. Mild dilatation of the left atrium or moderate dilatation of the left atrium, some tricuspid regurgitation with an RV systolic pressure of 40. Really doesn't seem anything abnormal. We see these patients all the time and say, okay, that's no problem. Just increase her blood meds. Let's just give her a little bit of diuresis if she needs. Is this patient having something? Her ECG shows left bundle. There is some ST depression in the lateral and high lateral leads, but it is going in incomplete left bundle. And actually, the other investigations showed grade 1 nephropathy in a diabetic lady or a diabetic elderly person. This is not something which is unusual. Her renal functions are normal. Her blood sugar is not very well controlled. But here again, and I would love, I thank Professor Hani Raghi for having his lecture before mine. By chance, an N-terminal proBNP is elevated. And here is another important thing that sometimes in patients with which we doubt the diagnosis, a little bit of N-terminal proBNP, these biomarkers for heart failure might even give us a clue on what's going on. So the question is here, definitely she's not in HFrEF, she's not in reduced ejection fraction, but is this HFpEF? Is this a correct diagnosis? Well, I go back a couple of days ago, actually, when there was publishing of the latest consensus on the classification of heart failure according to the European Society of Cardiology. And they introduced this new terminology, which really makes a lot of sense, this heart failure with improved ejection fraction. I know the American, on the opposite side of the Atlantic, they call it recovered, but actually improved. And here it says that this is heart failure with a baseline LV ejection fraction below 40 with a 10-point increase and a second measurement above 40. The other three categories, which are heart failure with reduced ejection fraction, mid-range ejection fraction, and preserved ejection fraction, are similar, as you can see, as before. We know ejection fraction, as it goes low, it's really bad. And a lot of patients, a lot of physicians, specialists or non-specialists, know that the ejection fraction is a problem. But actually, if the ejection fraction is from 45 and above, the prediction of mortality, prediction of outcomes is not really that accurate when taking ejection fraction by itself into consideration. So what can we do more for this patient? Is this patient really a HFpEF? Do we need further elaborate investigations? Do we need to do something else? Well, actually, you need some things which are very simple, which are always present. For example, this patient had an E over E prime ratio done, and it was found to be 14, and I'll show you what this means actually. This is not an intricate investigation. This is not a difficult thing to do with an echocardiogram. Instead of just having the left atrium, you can do the volume index, as you can render the volumes of the ventricle. The volume index of the left atrium is important as it's more accurate than just the dimensions. And if we look at the scores, this is the HFpEF score from Mayo Clinic, and it shows that this patient has 2 for being heavy, that is a body mass index above 30, being on 2 or more hypertensive medicines, she was on 2 actually, having an increase in the right ventricular systolic pressure, a pulmonary hypertension, an age above 60, and an E over E prime above 9. This goes up to an amount of 6, which gives a predictive value of HFpEF to around 90%. But if you do not like to play with numbers, I'll show you another algorithm that might help you. Let's say in the same algorithm that we used, or the scoring system, and this patient had a score of 6 to 9. Of course, the patient is coming with symptoms of heart failure, and we'll discuss that quickly. The left ventricular ejection fraction is above 40, and there are no other apparent causes of these symptoms other than probably HFpEF. If the score is 6 to 9, this is HFpEF. If the score is 0 or 1, this is probably not HFpEF. If it's in between from 2 to 5, here definitely an terminal pro-BNP or BNP is accurate, or assessment of absence or presence of significant lung disease. And if you're still not sure, invasive testing can help. So this is one of the scores used. The ESC has an HFpEF score by itself, actually. It starts with an initial workup of the signs, symptoms, and standard echocardiography, with the second step going to more comprehensive echo that we just showed, and natriuretic peptide if they were not measured in the initial workup. And then an advanced workup and an etiological workup if you suspect this patient has a cause like hypertrophic cardiomyopathy or amyloidosis, and these can be done through different modalities. But the HFpEF, Heart Failure Association PEF score of the European Society is more intricate. But I want to show for those who are pessimistic about the importance of biomarkers, especially the BNP and terminal pro-BNP, half of the investigations is towards biomarkers. And as Professor Mahmoud Hassanein and Professor Hani Raghi just said, it differs from sinus rhythm to atrial fibrillation. The cutoff points are different. And also, there are different measurements seen by echo, like the E prime velocity, the lateral E wave velocity, the E over E prime, which is very common, very simple to do. There could be also the global longitudinal strain, presence of the tricuspid velocity above 2.8. You don't have to memorize them. The left ventricular wall mass index and the left atrial volume index, and these can just be on your mobile phone, a piece of paper printed out, and this can help a lot to diagnose. But there comes a question, what if the patient has an indeterminate diagnosis of HFpEF? What else can be done as said, here comes the invasive testing, or what we call the advanced workup. And this invasive includes stress or invasive measurement through the pulmonary capillary wedge pressure. And here, at sometimes with stress echo, what seems as a normal E or E prime, which is below 14, or tricuspid regurgitation less than 2.8 meters per second, can increase during exercise, showing that this is HFpEF. Also, invasive hemodynamics can be used, showing an increase of the left ventricular end diastolic pressure and the pulmonary capillary wedge pressure, and this can help diagnosis of HFpEF. So coming back to the symptoms and signs that we skipped in the beginning, is HFpEF similar to HFrEF? Is it considering signs and symptoms which are very essential in the diagnosis of heart failure? Actually, believe it or not, yes. Maybe there is sometimes an increase of signs, especially in HFpEF, but definitely the significant difference always that HFrEF shows definitely cardiomegaly and a third heart sound more than HFpEF. And mortality and morbidity in HFpEF is similar to that in HFrEF, maybe a little bit more, maybe a little bit less, but in some studies, it was really much more than other HFrEF studies. So how do we manage these patients? I know we have an outstanding lecture coming up by Professor Ashraf Reda, Bridging the Gaps. I will just take a little bit of slides on looking at what we have for these patients. Looking for HFpEF, not only for diagnosis, but also for management, we should look at the pathophysiology, which is multifactorial. It's not just the remodeling that occurs in HFrEF. There is a lot of problems, whether it's in the RV or pulmonary vascular tree, atrial fibrillation present or not, volume overload or remodeling, or others. And the ESC guidelines, which were last updated in 2016, say that we should give congested patients diuretics, whether it's HFpEF, HFrEF, or even mid-range ejection fraction. Are there medications that improve symptoms? Well, definitely diuretics. Are there medications that improve hospitalization? Well, it's seen in the seniors trial with nebivolol, some patients in digoxin, spironolactone, and candesartan from the CHARM preserved. But mortality is not seen throughout all the medications seen. The ACC/AHA guidelines, I know they updated the HFrEF in 2021, but actually in talking about HFpEF, we have data from 2017. Again, looking at the same results as the European guidelines. I don't want to bore you so much. So actually, risk control, controlling the heart rate, restoring sinus rhythm if the patient is in atrial fibrillation, and weight reduction or congestion, we give diuretics. We know exercise has a lot of benefits on the pathophysiology of a lot of diseases, and it has been shown to improve hospitalization and improve the E over E prime, the left atrial volume index, and even the quality of life. And diet and exercise have actually improved also the symptomatic improvement in those with preserved ejection fraction. But does this mean there are no trials with any benefit? Well, actually, most of them did not show any benefit. If you look at all of these trials, I'm trying to show you the outcomes, the primary outcomes were not met in all of these studies. Maybe in TOPCAT, but the results depended on which region in the world that it was being conducted, not actually on the type of patient. But this is, again, heterogeneous. And this was the why spironolactone was given a query improvement in outcomes in HFpEF. Then came sacubitril. We know Paradigm has shown improvement. I'm not going to go into this in detail, but this was the HFpEF data from Paragon for usage of sacubitril versus valsartan, and it missed the primary outcome just by a few events. But actually, there was a trend, and there was a significant reduction in some adjudicated reported events. This was significant as in comparison to the second arm. But what was more important, that there was a consistent, significant improvement in the primary endpoint in females and in those with an ejection fraction of 57 or below. And this is why last December, actually the FDA approved to give it, but they did not agree on how. But this paper just published a few days ago, and thanks Professor Atif for sharing it with us, has given us like a case of when to use sacubitril valsartan with preserved ejection fraction. Maybe those with more than one relevant clinical factor, like the female gender, those with a borderline ejection fraction, not those in the 60s, or those with a recurrent or recent heart failure hospitalization, might benefit. There are other drugs like the cyclic guanylate cyclase stimulator, vericiguat. There are data probably this year, Emperor preserved for SGLT2 inhibitors might go out. Deliver, I'm not sure it's this year or next. There are others like the carboxymaltose. We're waiting for the data. Patisiran in amyloidosis and mavacamten in hypertrophic cardiomyopathy had showed some improvement of outcomes. This is really outside, but again, we do not have definite outcomes. There are also devices that are being under investigation to reduce the tricuspid regurgitation and also the mitral regurgitation. So not to take a lot of your time, this is a complex entity, heterogeneous. It's not similar to any other disease that we have. It has intermingling with many different problems. Symptoms and signs are very similar to those of HFrEF. A thorough investigation and examination, and here biomarkers are extremely important because you might have an acute event with a patient coming with pulmonary edema with signs of failure. His echo is okay, and we're not really diagnosing. A simple biomarker test, and these biomarkers, actually, I agree totally, Professor Hani Raghi, that they are now present in most places in Egypt, and they don't cost a lot of money. But the most important thing about HFpEF is not just diagnosis. We don't have actually so much data on the management. And as more trials are conducted, we're getting a clear picture on how to manage these patients. And thank you so much.
Thank you, Professor Ahmed, for this elegant presentation. I would take the permission of my colleague panelists to kick the first question.
Okay, proceed.
Every time Professor Ahmed, any professor is slated to speak about heart failure with preserved ejection fraction, I feel sorry for him or her. Complex etiology, no proof in therapy that provided significant survival benefit in this complex entity, as you say. However, the general consensus now is to look to the ejection fraction as a single continuum. This means that in the future, we might not have this distinction between HFrEF and HFpEF. We will look to the ejection fraction as a continuum. The ejection fraction 45 is better than 50, and 40 is worse than 45. And as you said, the FDA gave a nod up for sacubitril valsartan in HFpEF based on a pooled analysis from Paragon Heart Failure and Paradigm Heart Failure, in which the investigators showed a graded inverse relationship between ejection fraction and outcomes when the patients are using sacubitril valsartan. My first question is, what's your take on this look to the ejection fraction? It's a continuous variable rather than we have a distinction between HFpEF and HFrEF. The second question, would you go for sacubitril valsartan in this patient if she did not improve on the conventional measures?
Very good questions, very good points. Ejection fraction is ever-changing. There's a lot of intra-observer variability. And actually, just using the ejection fraction for heart failure is not enough. We need to use more biomarkers. We need to follow up the symptoms and signs and biomarkers here like N-terminal proBNP. Would I give sacubitril? I would love to give sacubitril valsartan to all my HFrEF patients, and probably will give it to a lot of HFpEF patients which are not improving. Will it be a guideline recommendation? That is the question. This is a very important question. And this year, we're waiting for next September when there is publishing of the ESC guidelines. So far, it is recommended by the FDA in certain patients. There is a making of statement when to write it. I think it will be given an okay because we don't have anything really that showed improvement in HFpEF.
Thank you.
My comment on what you have said, Ahmed, هو if BNP and pro-BNP has any role to play, it is just for the HFpEF patients. By revising the data that you have just presented to your patient, and this is, I think, a common practice, that echo will solve the problem with the HFrEF, with the heart failure with reduced ejection fraction. There is no need to do BNP anymore, except for prognostic purposes, which is rather academic. But for diagnosing a patient like your patient with shortness of breath, with lower limb edema, with all the manifestations of heart failure and normal ejection fraction or preserved ejection fraction, I think that BNP has a pivotal role in this regard, at least to exclude heart failure if being negative or of being below the normal. So this is my first comment. The second comment is about the mid-range, the 40-50 mid-range. I think that the new definition that you have just referred to are giving it a new name, which is the MR instead of mid-range to mildly reduced. So I think they are pushing it towards the reduced ejection fraction. And this is, I think it's logical, because some of these patients were included in trials of the HFrEF with good results. So now if you have a patient with 45, 47, I think you can easily give them all the successful, between brackets, treatment like the ARNI, like the SGLT inhibitors. I think by this new definition, there might be a change in the way we are dealing with patients with mid-range. Now they are called the mildly reduced ejection fraction. Thank you.
Lovely comments as usual, Professor Samah. Thank you.
Ahmed, what about the use of this group of ARNI? Do you expect that the ejection fraction will get improved to reach 50 at least? And this is an indication to show an improvement in the mid-range, like reduced. Do you recommend the first steps of treatment of HFpEF with mid-range or not? The use of ARNI?
Okay, mid-range is or mildly reduced. Actually, I really read about it a little bit in detail. Mid-range is of remodeling. There is so many data more towards HFpEF actually than HFrEF, but there is some data towards HFrEF. There is a lot of questions. I think, like Professor Samah just discussed, I think HFpEF is above 50, HFrEF is below 50. It's not normal. Call it mild reduced, call it a little bit of reduced, call it mid-range, whatever. I think there will be a little bit of remodeling occurring in most cases of mid-range and HFrEF. Yeah.
The problem is that they are orphan patients. No data, no full data for this gray zone. So we are waiting for data just to see which is the best treatment for this mid-range or mild reduced.
دكتور سامح، كان الميتا اناليسيس اللي كان طلعت من ايام قالت انه الارني از وركينج في البيشنت من 43 لغايه 49%. Do you accept this paper؟ كان ميتا اناليسيس قال انه اليوز اوف الارني is accepted with good results in a patient with ejection fraction from 43 to 49.
ممكن
Do you accept clinically؟ دكتور محمود اتفضل.
بص، هو في الببليكيشن اللي قال عليه احمد بنداري اللي هو في اناليسيس، هم عملوا حاجه ظريفه قوي. خدوا البيشنتس فروم ذا باراجون والبارادايم، حوالي more than 13,000 patients، و they imputed السكابتير فازرتان versus بلاسيبو. يعني هم اعتبروا، انتوا عارفين في البارادايم كان الانترستو فيرسس انالبريل، كان الانترستو فيرسس فالزارتان. فهم بولد داتا من 13,500 عيان وامبيوتد الريزلتس فيرسس بلاسيبو. لو كانوا خدوا بلاسيبو لقوا ان البينفيت فروم الانترستو از اب تو ان ايجكشن فراكشن اوف 55%. لغايه 55% كان في improvement, significant improvement. لما we crossed the limit of 55%, there was no more improvement. والكلام ده لاحظوه لما عملوا ميتا اناليسيس مع البيتا بلوكرز ومع المينرال ريسبتور انتاجونست والاذر اس انهبيتورز، بمعنى ان في benefit of all therapies of HFrEF up to an ejection fraction of 55%. الentity of heart failure with mid-range ejection fraction التسمية دي خلاص اختفت في النيو كلاسيفيكيشن اللي هو الببليكيشن اللي طالع من الهارت فيلير سوسايتي اوف امريكا مع الهارت فيلير اسوسيشن مع الجابانيز، قالوا ما فيش حاجه اسمها ميد رينج، قالوا heart failure with mild reduced ejection fraction. And these patients do benefit definitely for all treatments اللي هم بياخدوها العيانين اللي هي HFrEF including ARNI. اوكي، فاعتقد ده السبب ان هم ادوا extended use. الكلام اللي اشرف رضا اظن هيتكلم عليه extended use of ARNI up to an ejection fraction of 55%.
I think we can, if you allow me to conclude the sessions and take a break for 30 seconds and back for the last presentation.
Now we have the symposium of reports. It will be a presentation by Professor Dr. Ashraf Rida, Bridging Gaps in Management of HFpEF. Dr. Ashraf.
Thank you, Professor Atif, and actually it's a pleasure to have this great faculty with us in today's CME activity about heart failure, and I would present these presentations in an industry-supported CME activity from Novartis. So, bridging I think the gap in HFpEF management and diagnosis was very clear in the previous presentations. Heart failure with preserved ejection fraction is a complex entity, difficult to diagnose, and there is no real proof of any drugs that can help our patients with heart failure with preserved ejection fraction. Until recently, we have some data. And actually, the presentations and papers about this entity is more than this is maybe 35 or 40 years ago. Congestive heart failure with normal systolic function, intact systolic left atrial function in clinical congestive heart failure. So years ago, despite these long decades, many decades of trying to find specific criteria for diagnosis, specific management strategy, despite that, guidelines in 2012 for ECC guidelines, no treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFpEF. And even in 2016, I think the same statement, no treatment has been shown to improving morbidity and mortality in patients with HFpEF. So HFpEF is the single greatest unmet need in cardiology. It is a complex disease. The prognosis is worse, however, difficult in diagnosis and difficult in management. So, first of all, why heart failure with preserved ejection fraction is an important issue to talk about. If we look at these, get with the guidelines, heart failure registry, managed by the American Heart Association and the American Stroke Association, they concluded that if we look at the heart failure with ejection fraction more than 50%, those with 35% to less than 40%, and those to 15% ejection fraction, there is increasing heart failure preserved ejection fraction by 1% per year relative to heart failure with reduced ejection fraction. And actually, there is many explanation for that. One of them is the difficulty in diagnosis. One of them is the coding of the patient on discharge, because some rules for the insurance company in the Western countries put the patient with diagnosis of heart failure in a specific category. So sometimes they write hypertension, but don't mention that this is heart failure for insurance purposes. So according to this trend, it is expected by 2020 that 65% of hospitalized heart failure patient will have ejection fraction more than 40%. So you have to prepare yourself to treat or to manage this important problem. If we look at the trend in the incidence of heart failure hospitalization, what is the percentage of heart failure patient? If there is a decline or increase in heart failure hospitalization, if there is a decline or the increase in morbidity and mortality, what are the causes of morbidity and mortality? It is cardiovascular causes or mainly non-cardiovascular causes. I think this is an important registry, the Olmsted County. And this Olmsted County is a state in Minnesota, in USA, with about 140,000 inhabitants. They look at the patient with heart failure and in about 10 years of heart failure following the patients of heart failure. And actually, they quote this conclusion, that the proportion of incident cases of HFpEF is increased from 47% to above 50-something% in these 2 years. And actually, when I looked to this paper, I found that there is generally decline in heart failure hospitalization, but the decline was more sharp in heart failure with reduced ejection fraction and was less in heart failure with preserved ejection fraction. That make the difference. And maybe the explanation is those group of patients with heart failure with preserved ejection fraction are usually an elderly population with many comorbidity and many non-cardiovascular causes of hospitalization and admissions, and even the mortality in them may be related more to non-cardiovascular causes like respiratory causes, like cancer, like other causes of non-cardiovascular mortality. So despite there is decline in generally in heart failure, hello? I'm still in online.
I'm hearing you well.
Well, أنا مش عارف أقلب السلايد ليه. ممكن أعمل اسكيب كده. So sorry for this technical problem, and we will be back again with you. So the proportion of incident cases of heart failure with preserved ejection fraction is really increasing in this Olmsted County in the United States, in USA, Minnesota state inhabitant. Incident heart failure with preserved ejection fraction, it was noticed that the prevalence of hypertension, diabetes, hyperlipidemia, and comorbidity increased over time, and those are the main causes of admission and the main causes of mortality in this category of patients. So, how to compare the phenotypes, the two phenotypes, preserved ejection fraction or heart failure with reduced ejection fraction? Really, heart failure with preserved ejection fraction is a major public health problem. And there was no improvement in outcome over the past decades of treatment of heart failure in general, whatever the medication you are using. If you compare this with heart failure with reduced ejection fraction, we have a lot of medication that proved to be effective. Maybe that most of the trial previously using treatment was against the placebo, but unfortunately, the results were, as Dr. Ahmed Shawqi was presenting, were nutrient in most of them. Backing to the Olmsted County registry, if we look at the hospitalization after heart failure diagnosis, it was noticed that total hospitalization rate for HFpEF and HFrEF were similar and did not change over time. So there is generally a decline, but as I told you, the decline is more in HFrEF hospitalization compared to HFpEF, which is relatively increased in hospitalization now. So the clinical outcome in heart failure with preserved ejection fraction, heart failure hospitalization, we have evidence based on observational study that we have high rate of heart failure hospitalization in HFpEF and HFrEF. However, a higher rate, this is very important, of non-heart failure readmissions is observed among patients with HFpEF patients. So heart failure and the cardiovascular readmission in patients with HFpEF, 10% readmission within 30 days of hospital discharge, 37% readmission within 1 year. And according to the 5-year outcome analysis of patients in the GetWith guideline heart failure registry of the American Heart Association, a lower rate of heart failure readmission was observed in HFpEF patients. So in HFpEF patient, the readmission is usually due to the other comorbidity that require, that is the cause of readmission and the cause of mortality and morbidity. And this is a real problem because we have a complex syndrome with multiple comorbidity that require frequent hospitalization, and we have no effective treatment. That is very serious situation. And actually, if you look at the repeat hospitalization, unfortunately, total hospitalization rate for HFpEF and HFrEF were similar, and this is translation of the previous slides with some cartoons and number. So for patients with HFpEF, rehospitalization is not a matter of if, but a matter of when we will be hospitalized. This is the effect of HFpEF on the quality of life. And actually, as Dr. Hani Raghi was explaining, a grandmother with a multiple comorbidity with heart failure, actually, there is a lot of diminishing of the quality of life regarding shopping, regarding climbing stairs, even working in the garden, even maintaining intimate relationship, visiting family and friends. So actually, HFpEF robbed the patients of their independence and going what they love most. Is important disease affecting our quality of life. So I think we can conclude that HFpEF is just a mix of comorbidity that is responsible for frequent rehospitalization, responsible for frequent readmission and mortality. If we look at the clinical trials of heart failure with preserved ejection fraction with the blue color, compared with the clinical trials with other cardiovascular trial like the ACCORD trial, LIFE, the value, the ALLHAG, the HIVET, comparing the overall mortality in these trials, you will notice that the trials of the heart failure with preserved ejection fraction is characterized by a higher rates of mortality. This is in general for such patients compared to other cardiovascular trials. And even the hospitalization, if we compare hospitalization in the HFpEF trials compared to other cardiovascular trials, it's clear that hospitalization is higher in those patients. So what are the pathology? What is the pathology of pathological mechanisms of heart failure with preserved ejection fraction compared to heart failure with reduced ejection? There is a significant difference and variability in the pathophysiology of both. In heart failure with preserved ejection fraction, the comorbidity like hypertension, overweight, diabetes lead to microvascular inflammation and endothelial activation. This is the main comorbidity, and this subsequently can lead to decreased cyclic GMP in the cardiomyocytes and microvascular ischemia, concentric left ventricular remodeling. However, in heart failure with reduced ejection fraction, we have direct cardiomyocyte energy, like cases of acute myocardial infarctions, infections, toxins, and this direct myocardial injury lead to cell necrosis apoptosis, and eccentric left ventricular remodeling with subsequent neuroendocrine hormonal reactivation. As Dr. Ahmed Shawqi explained, that we have many molecular targets as a possible mechanism of treatment of patients with preserved heart failure, preserved ejection fraction, according to this pathophysiological mechanism, whether at the cellular level it changes, whether in organic nitrates and nitrites, whether the ARNI, of course, and the PD, even the phosphodiesterase inhibitors can theoretically help patients with heart failure with preserved ejection fraction. If we look at the treatment, have we in the last decades have an important treatment that proved to be worth it with patients with HFpEF? Actually, if we look at the many clinical trials, this is a list of clinical trials. This is a list of drugs like ACE-ARBs, irbesartan, low-dose carvedilol, beta blocker, digoxin, spironolactone, enalapril, nepivelol, spironolactone, and keeping in mind that all of these trials comparing this drug against the placebo, and despite this, most of the results are neutral, with no significant effect on hospitalization, on mortality, and on morbidity and other endpoints in these trials. So the only recommendation we had in the last decades is that diuretics are recommended in congested patients with HFpEF or mid-range or mildly reduced ejection fraction in order to alleviate symptoms and signs, and that was the only recommendation we had. Even if we look at the outcome of these trials, considering patients with HFpEF, despite they are drugs against the placebo, PEP, congestive heart failure, TOPCAT using spironolactone, irbesartan in the iPreserve, candesartan in the CHARM preserved, there is no significant endpoint reduction. Maybe the only one using the angiotensin receptor blocker here may touch the significance, but there is a trend to some improvement using angiotensin receptor blocker inhibitor. So ARBs, I think, was the only class of drugs that have some or showed some benefit in patients with, and keeping in mind that was compared with placebo. So what about the angiotensin receptor neprilysin inhibitor, ARNI, in heart failure with preserved ejection fraction? If you look at the phase 2 double-blind randomized trials published in 2012, we'll notice that these drugs are safe. We have used it in reduced ejection fraction. We know that it's safe. And if it is tried in heart failure with preserved ejection fraction, we have evidence that it can work. We have evidence that it can improve the NT-proBNP, can improve the left atrial size, and it can improve the NIHA class, and compared with valsartan, the angiotensin receptor blocker. So these trials compare the drug against ARBs, which is the only class of drugs that showed some benefit. So it is not compared with placebo, even when compared with angiotensin receptor blocker. And as Dr. Mahmoud Hassanein explained, if we put an algorithm or mathematical way to extrapolate the effect against the placebo, it will be much more even beneficial. So sacubitril valsartan or Sac-Val is the only medication with some positive phase 2 data in HFpEF, and that was in the Paramount trial, showed this beneficial effect of this combination or this drug in ARNI in some parameters. What about the Paragon heart failure? What is the lesson from Paragon? The first observation is Paragon is that we are using ARNI, trying to show its effect on the endpoints compared again to valsartan. So we are using sacubitril valsartan 200 milligram BID compared to valsartan 160 milligram BID. And if we look at the primary endpoint, the recurrent event analysis of the total heart failure hospitalization and cardiovascular risk, and actually there is trend tower improvement, 13% reduction in the risk of the primary endpoint, and the p-value is 0.59. And of course, as you know, this trial using ARNI in compared to valsartan, not ARNI against placebo. However, if we look at sensitivity analysis of the primary endpoint, we will see some beneficial effect on the primary analysis, including urgent heart failure visit in composite, investigator-reported event. That was the one showing. If you look at the secondary endpoint, NYHA function class at 8 months changes was significant improvement using sacubitril valsartan. The quality of life clinical summary, some improvement. The responder even some improvement, but however, all-cause mortality, there is no difference regarding all-cause mortality between the two groups. What about the primary endpoint according to the ejection fraction and gender specificity? Actually, we have heterogeneous results regarding this issue. It looks like the female may benefit more from this combination, at least in this trial, and those with lower ejection fraction have more benefit if using ARNI. But what is the cutoff value of ejection fraction? Definitely, those with ejection fraction above 60% showed no benefit. However, if the ejection fraction is below the median 57%, so you have a high percentage of patients you see in your daily clinical practice with heart failure, with an ejection fraction is say 50%, 48%, even 55%. So up to 60% there is some benefit compared to those with above 57. So in the only interactions for sex and ejection fraction remain nominally significant in this secondary endpoint analysis. And this is the treatment effect by ejection fraction quartile. This is the overall results. This is those with less than 50%, 50% to 75%. All these are significant p-value. However, above 57% and above 60%, there may be no benefit using this drug. That leads to some changes in the our concept about using sacubitril valsartan across the spectrum of ejection fraction in heart failure. This is original research article, and in this research, in this pooled individual patient level analysis that was explained by Professor Mahmoud Hassanein in his comment, using 13,000 patients with heart failure enrolled in the Paradigm and Paragon heart failure trial. Paradigm, patient with reduced ejection fraction, and the Paragon patient with preserved ejection fraction. They were examined patient profile, clinical outcome, and treatment response to ARNI compared with an active RAS inhibitor comparator across left ventricular ejection fraction spectrum. This is the Paragon heart failure and the Paradigm heart failure combined together. We can conclude that the efficacy of ARNI added by left ventricular ejection fraction with greatest treatment benefit observed in patients with left ventricular ejection fraction below normal. Moreover, the treatment effects across the ejection fraction spectrum were further modified by sex, such as the therapeutic benefit appeared to extend to a higher level of ejection fraction in women compared to men. And as Dr. Ahmed Shawqi and Dr. Bendari and all the faculty mentioned, that FDA panel puts some changes regarding heart failure with preserved ejection fraction in 2020, last December. FDA panel puts spironolactone in play for heart failure with preserved ejection fraction and support expanded heart failure role for sacubitril valsartan in this important category of patients. And we have 16th of February this last month, new FDA indication opens up use of sacubitril valsartan in HFpEF patients. That was in the news, and this was a statement to reduce the risk of cardiovascular death and hospitalization for heart failure in adult patients with chronic heart failure. Benefits are most clearly evident in patients with left ventricular ejection fraction below normal. So I think I can now deliver my take-home message. My take-home message is that no treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFpEF according to the ESC guidelines. So we have a serious disease and no treatment, many treatment tools. International guidelines recognize the complexity of diagnosis and the non-specificity of symptoms and the need for objective evidence. So we need objective evidence treating this serious disease. ARNI is the only medication with positive phase 2 data as seen in the Paramount trials, and keeping in mind that it was compared to valsartan, not compared to placebo. Many drugs failed despite comparing to the placebo, and when ARNI used comparing to ARB, it showed some benefit in Paramount. Paragon Heart Failure demonstrated a potential benefit of angiotensin receptor neprilysin inhibitor with SAC valve combination compared with valsartan again in reducing heart failure hospitalization in patients with heart failure and left ventricular ejection fraction above 45%. Thank you very much.
Thank you very much, Professor Ashraf, for your elegant presentation. And I have a comment here. If I collect all this data from the FDA, recent FDA, and from the European Society of Cardiology, and put it in a sack to improve the HFpEF-related morbidity and mortality among patients with HFpEF, the sacubitril valsartan could be used in patients with HFpEF, and if they have more one relevant clinical factor, female gender, or borderline or mildly reduced systolic function, recent heart failure hospitalization. So if this is clear and they open the door for us to prescribe that for HFpEF, can we agree all together to implement this for our patients? Especially we face many patients in our clinics and hospital. They are female, they are obese, they are diabetic, hypertensive, and they have to be hospitalized for dyspnea or pulmonary edema, and they are HFpEF. What do you think about it? And I ask all my colleagues, Professor Syed Farag, Professor Hassanein, Professor Samah, we should share all the opinions all together.
Okay. This is very important question, Atif, actually. First of all, there is no medication fits all. We have to tailor our medication to our patients. So we may put priorities of using ARNI in patients with heart failure with preserved ejection fraction. I think the first indications, if we have to put some indications, is, as you said, obese female with multiple comorbidities, and the ejection fraction is 45 to 50%, for example. The second category is anyone with heart failure with preserved ejection fraction.
Actually, I have, I don't know, you hear me?
Okay, Syed.
Okay. Actually, there is 6 million US population suffering from chronic heart failure. About 45% of them are those with heart failure with preserved ejection fraction. So far now, 1 month ago, we have an FDA approval for using extended use for sacubitril valsartan. So I think that the sacubitril valsartan will be implemented for those patients who are more than 2 million US population. And I think out of evidence, we will get a practical point of view after those patients will be given the sacubitril valsartan by the FDA approval. I think this will be a great shift in the management of heart failure after those over 2 million people with heart failure with preserved ejection fraction in the US population will take the sacubitril valsartan. This is a point. The other point, a few days ago also, there is a very appealing publication in the International Journal of Cardiology, at least for me. They are subclassifying the heart failure with preserved ejection fraction for clinical subclassification to 6 groups. I think it is very important to mention that those groups are subclassified according to the presence of diabetes, hypertension, atrial fibrillation, chronic kidney disease, 1 or both or 3 of them, to make a 6 subclassification of heart failure with preserved ejection fraction. I think this subclassification will be reflected to our management strategy. My last point here is a question, Dr. Ashraf, is about the global longitudinal strain for detecting the hidden systolic dysfunction. Do you think it will change the face of the management of heart failure with preserved ejection fraction on taking in consideration the impaired global longitudinal strain by ECHO?
Well, I think this is an important question, Syed, because I was trying to tell that the most important issue in diagnosing this syndrome is to diagnose heart failure. I'm not an echo man, but you have to first clinically diagnose that your patient have heart failure. Then look at the ejection fraction. If the ejection fraction is normal or in the mid-range or mildly reduced, you can put patients either in HFpEF or mildly reduced ejection fraction. So clinical diagnosis of heart failure using a biomarker and look at the ejection fraction. This longitudinal strain issue is maybe have more important role in the prognosis of the patient. And maybe it is very important in assessing those patients with recovered ejection fraction or improved ejection fraction. For example, if you have patients with postpartum cardiomyopathy, with low ejection fraction, you give her treatment for months, and then you find the ejection fraction become normal. Do longitudinal strain. If it is abnormal, your patient may benefit from ACE inhibitor, ARBs, or ARNI for long-term.
Dr. Ashraf, this is Nabil Farag. I'm still here.
Okay, Nabil.
Do you hear me?
Yeah.
Yes,
sure.
Dr. Nabil.
I would like to just a comment on heart failure with preserved ejection fraction, and we discussed this before, Dr. Mahmoud, that patients with heart failure with preserved ejection fraction are usually underdiagnosed because they presented usually to the hospital with comorbid conditions, usually presenting patients, for example, with atrial fibrillation, are treated as an atrial fibrillation patient with ischemic heart disease, patient with hypertension, chronic kidney disease. They are treated as this entity, not as a patient, as a final diagnosis of a patient with preserved ejection fraction. I think the failure of most of the trials in achieving a good results with the different medications in managing heart failure with preserved ejection fraction is that they are addressing a syndrome. Patient heart failure with preserved ejection fraction is due to actually these comorbid conditions. So we have to treat mainly the underlying etiology. In a patient with ischemic heart disease should be treated properly. In a patient with atrial fibrillation, either rest control or rate control is recommended. In a patient with hypertension, in a patient with chronic kidney, all of these patients, we have to target first the comorbid conditions, then look at the symptoms and using the other drugs, for example, using sacubitril, valsartan, ACE inhibitors, ARBs, in addition to proper management of the underlying etiology of this important syndrome. This is just an opinion, my opinion. And I would like to hear your opinion about why all of these trials, even the Paragon trial, didn't achieve the results we are expecting to have from this.
I think if we, the old trials using many drugs against placebo, ACE inhibitor, beta blocker, ARBs, was neutral results, except some benefit from the ARBs candesartan in the iPreserve trial. ARNI is different issue, because if we look at the results of the ARNI in view Paragon trial, for example, in view that that was drug ARNI against angiotensin receptor blocker. So you are working or doing the trial against a drug that may have some benefit in patients with heart failure with preserved ejection fraction, at least based on the results of iPreserve trials. And when they extrapolate the data, if this data, ARNI was against the placebo, the results will be very significant. This is the first point. Second point, if you look at the secondary endpoints, some endpoint actually touched significantly, and some endpoint was significant, especially those with the ejection fraction is not super normal. Yani you don't give the drug to one with heart failure and the ejection fraction is 65%. But if the ejection fraction is below 57%, we have now evidence that there is some data. And I'm sure, as Dr. Ahmed Shawqi mentioned, that the next guidelines is in September will show some important changes regarding the use of ARNI in heart failure with preserved ejection fraction. Do you have any comment, Dr. Mahmoud?
والله هو بص يعني I think الديفرنس ما بين الهاف ريف والهاف باف in half ref there is direct myocardial injury, direct myocardial insult, and so we have treatments which are beneficial in this group of patients. In patients with a heart failure with preserved ejection fraction, there are multiple comorbidities which cause systemic inflammation, systemic inflammatory state, which will then affect the myocardium and the microvasculature. So the pathophysiology is quite different. We are not successful at treating HFpEF because of the multiple comorbidities. There is no direct myocardial insult as in HFrEF. The pathophysiology is totally different. Like I think some patients with HFpEF, as we have seen, up to an ejection fraction of perhaps 55% will benefit. I think SGLT2 inhibitors will achieve some progress in treatment of HFpEF. Why? Because patients will have hypertension, diabetes, and they are elderly. And we are expecting the results of Emperor preserved and Deliver preserved in this year and the next year. I think we'll have favorable results.
But just a comment, Dr. Ashraf, because we don't want to generalize that we have to use some drugs in all patients with heart failure with preserved ejection fraction. That we have, even if we are going to use these drugs, we have to select the patients with heart failure with preserved ejection fraction who are going to benefit from these drugs. And you mentioned, and the trials mentioned very clearly, that still patients with an ejection fraction below normal, those are the patients who are getting benefits from these drugs. You know, it's our job to send clear messages to those who are hearing us, and to be clear as regard the way of management of this patient. That's I want to tell.
Yes, I think we can conclude that according to the Paragon trial, the lower the ejection fraction in patient with heart failure with preserved ejection fraction, and especially in female, the more the benefit. Okay.
So we have to conclude.
Agree with me, Nabil?
Yes, I agree, totally agree with you.
Okay. So I think, Atif, you can conclude the session.
We thank all the colleagues, dear friends, for this nice cardioresc wave.
So at the end of this CME activity, I would like to thank all the panels. We have great panels of Dr. Mahmoud Hassanein, Dr. Nabil Farag, Dr. Samah Shaheen, Dr. Atif Al-Bahri, Dr. Said Farag, of course, all the speakers and faculty, Ahmed Al-Irsh, Shafi Tabla, Ahmed Bindari. I don't want to forget anyone. I want to, before those and after those, to thank the attendee for being with us till the late night, and I hope you enjoyed the presentations of the faculty and get the message correctly, and see you in the next CME waves. See you all. Thank you.